Hi, everyone. Thank you so much for joining us today for our HBI 101 talk, Addiction 101. We're very excited to have with us Dr. Kathryn McHugh. She is Chief of Psychology at McLean Hospital and an Associate Professor in the Department of Psychiatry at HMS.
Will understand not only why.
Sorry. Oh, okay.
But they're going to be proud of you.
She's also the Director of Stress, Anxiety, and Substance Use Lab at McLean, a practicing clinician as well as a researcher. Her research is on the nature of anxiety and substance use disorders and how best to treat them. She also specializes in CBT, cognitive behavior therapy for anxiety, depressive, and substance use disorders. Her work is funded by grants from the National Institute on Drug Abuse, and she is a standing member of the NIH Interventions to Prevent and Treat Addiction Study section. She has numerous research articles and also has written many book chapters and is the editor of a book on evidence-based treatments in mental health. She's received a lot of awards, including the David Shikoff Early Career Award for Distinguished Scientific Contribution to Clinical Psychology, which is given by the American Psychological Association. And from McLean Hospital, she's received the Ann M. Cataldo Excellence in Mentoring Award. And we're really happy to have you here. Just a couple of housekeeping notes. If you have signed up for the lunch, please come to the front. And if you've not signed up, we still are happy to have you join in. And for people on Zoom, feel free to type questions at any time. So thank you so much for coming.
Thank you. Thank you so much. It's like the politest little clap I've ever heard. Thank you. What a nice group. So thank you so much for the chance to be here. If I'm yelling too much either for folks in the room or on Zoom, please let me know. I tend to get a little excited about this topic, so I will try and modulate as best I can. So I'm so excited to be here talking about this topic. Addiction, doing sort of a 101, I always find actually really grounding for me and good for me to sort of just take a step back and think about what are we looking at with addiction very broadly. And the mistake that you make in inviting a clinical psychologist to talk about this topic is I'm going to talk a lot about context and where context actually intersects with individual differences. So I actually want to start one piece of context that I think is really critically important for us to think about with addiction. And I'm going to talk mostly about substance use disorders, although I will spread out to other addictions at some point here. Is there are a number of ways that these disorders are actually quite distinct from any other psychiatric disorder. And these distinctions have all kinds of implications for everything from policy to stigma to treatment. So if you think about, and folks can feel free to type in the chat or folks who are here, any guesses about what are some things that distinguish substance use disorders from any other mental health disorder? Any guesses? I don't want to throw something out. Yeah, please.
People think you can control it.
People think you can control. We're going to talk a lot about control. So hold that thought. We are going to come to that. Control is absolutely critical when we're talking about this. Other things. Yeah.
I wonder if geography matters because the access to different substances is different areas.
We're also going to talk a lot about that. Access and availability of substances will make a huge difference in terms of what particularly a local landscape might look like. If you have a substance use disorder, where are you likely to end up? There's a decent chance you might end up. I see you smiling.
In a rehab.
In a rehab or
Homeless.
homeless.
Jail.
Jail. This is the only psychiatric disorder, and actually the only, someone could probably test my logic on this, the only disorder I can think of where the core behavior is actually criminalized. Now, obviously not in all cases. Alcohol is legal at a certain age, tobacco is legal at a certain age, cannabis is, depending on where you are, but this is the only disorder for which the core symptom, you cannot have this disorder without this symptom, in many cases is criminalized. And you can imagine all the implications that has. Another place where they're distinct, let's say someone in this room, someone on Zoom, has the cure for addiction, you figured it out. You're going to announce it tomorrow, you're going to put the rest of us out of business. When you announce this tomorrow, who is going to be unhappy with you?
Patients.
So the patients, depending on what stage of recovery, patients might be unhappy. Someone's going to be even less happy with you. Whoever has come up with this cure. Who stands to lose?
The prison industrial complex.
prison industrial complex. Yes, you're gonna have all the, maybe we shouldn't put this on YouTube, all the privatized prisons. Alcohol industry, the tobacco industry, the cannabis industry. You are talking about trillions with a T of dollars in industry, much of which, and there's evidence for this, alcohol, for example, majority of profits made by the alcohol industry are not on people who are socially drinking on weekends, but actually folks who have heavy drinking or alcohol use disorder. So you're looking at contextual factors that are tremendously important. Criminalization and the fact that there is an industry that has money to lose for every person who sort of comes out of this bucket of addiction. The one other piece of context I think is important is substance use disorders tend to be quite isolated from the rest of certainly health and even within mental health, both within practice and research settings. So for example, in the state of Massachusetts, the group that oversees substance use disorder treatment falls under a separate branch of our Health and Human Services department than does the rest of mental health. That happens in many states, that happens in many countries, where actually treatment is separated. And if you even get within the substance use disorders, you see further segregation of, for example, something like opioid use disorder and certain types of treatment programs that are regulated differently. They're in different locations than the rest of treatment. Even if we look at the NIH level, so there's a congressional cap on the number of NIH institutes, and within mental health, we have 3 institutes that cover mental health. Again, there's one institute for all of cancer. There's one institute for all of aging. There's one institute for all diseases of the heart, lungs, and blood. We have 3 within mental health, and alcohol and drug use disorders are separated out from the rest of mental health and also separated from each other. Now, there are certainly pros and cons to this, but this shows that we really have this sort of split off from other disorders. This is really important context as we're thinking about how are research funds allocated, how do we think about these disorders, how do we separate them from others. And if we add to some of this cultural context, there are tremendous value judgments about substance use, where you can see substances both glorified and stigmatized. And depending on what is the drug, depending on who is using the drug. Anybody think of a way that substance use can be glorified? Anything that you've heard? Where might you see a glorified image of substance use?
Artists.
Artists? Mm-hmm. Absolutely. Marketing? If you see an ad for a tequila, do the people look unhappy in that ad? Right. Is you tend to see, and there was a lot of controversy around this, particularly with the vaping industry and some of the early ads that were very much targeted to youth. If you looked at some of those ads, they were young, attractive people who looked like they were having the time of their lives. So you can really see this glorification. Any place else where you see that or hear that? It's just being glorified. Or...
We have some people on Zoom.
Yeah, please.
Movie, TV, entertainment industry.
Yep, movie, TV, entertainment industry, absolutely. Any place else, even in your social context. If you hear things like someone can hold their liquor, is that a good thing? But it holds sort of a positive connotation. Again, you see the stigma on the other end. This is also really wrapped up in cultural practices, rituals in many different directions, including substances being sort of barred depending on the culture, the religion, or substances actually part of cultural practices or rituals. There's also the historical distinction between, are these moral weaknesses or brain diseases? As sort of two sort of poles. And historically, substance use disorders really have been treated as moral weakness, and you still hear that in the language, and you still see that in many ways in some of our treatment contexts. And what does that sort of mean for this to be a moral weakness? If it's a moral weakness, treatment should look like punishment. Treatment shouldn't be fun, it should be hard. There should be a punishment element to it. You can really see that wrapped up into our treatments. You also see tremendous evolution in messages and norms over time. So, for example, people have been following the news on alcohol use. So changing recommendations about alcohol use and health. People have seen this. These kinds of messages, you could take any snapshot, any point in time, you're probably going to find 10 different news articles on there's a new standard about alcohol or tobacco or cannabis or other substances. These norms are constantly evolving. So why does this actually matter if we're thinking about the disease of addiction? It actually matters tremendously because as you move along the continuum of addiction, you will see shifting components of how much is this a cultural or societal or environmental influence, how much of this is a genetic influence, a family history influence, an individual difference influence. So we'll talk that through in a minute. I do always find it helpful to present a little bit of epi data just to give us a sense of what's the scope here. Anybody have a guess? So we're gonna do a snapshot. We're gonna do US-based data. In many ways we have probably the most robust surveillance data. So these are data from SAMHSA. If we took a snapshot, so past month substance use in adolescents and adults, so 12 plus, but what percentage of the population would you guess uses a substance in any given month? This includes all alcohol, tobacco, cannabis, heroin, you name it. Any guess? Percentage wise?
80%.
80. All right, there we go. Anybody else? 30%. All right, we've got a good range here. We got 80, we got 30. Price is Right rules. Anybody want to take a dollar?
Age bracket you're asking about.
So adolescents and adults, 12 plus. So it's about 60%. 80 is closer. If you get up to 80, almost quite honestly closer to 90 if you look at lifetime. If you're just looking at snapshot past month, about 60% of adolescents and adults in the US have used a substance. Probably unsurprising to people, the biggest group here is alcohol. About 100, just under 135 million people use alcohol in any given month. Tobacco comes well after that, then cannabis and nicotine vaping, sort of without a tobacco product. You then see these numbers drop down quite a bit. I'll give one caveat, just for anyone who is interested in the epi piece. These sort of quote-unquote more illicit drugs, the more heavily regulated ones, these are almost certainly underestimates just because it's a little bit harder to, again, a lot of folks in these categories are wrapped up in the criminal justice system. So things like methamphetamine and heroin are probably underestimates, but there's a whole lot of people, about 60% of the population. Now, what happens if we look at addiction? So we have use as one pole. Once we start to sort of whittle this down to who has a substance use disorder, my time scale is going to shift a little bit here just because the way we measure these diagnoses are looking at past year now. It's about 17% of the population. Again, this is adolescents and adults. About 17% had a substance use disorder in the past year. There are a couple of things that I want to point out here. One is you can see these numbers are a lot smaller than the numbers you just saw. So circle back to that for a second. So these numbers go way down, which tells you one thing, which is the majority of people who use a substance won't have a substance use disorder. And that's a really important piece of context, is sometimes we can have this sense of if someone uses X drug, inevitably they're going to have an addiction. That is absolutely not the case. Most people will not. That having been said, this is a lot of people. This is 17% of the population in the past year. This is 20, almost 30 million people with an alcohol use disorder. Almost a little over 27 million with a drug use disorder. So this is a tremendously large part of the population. Was there a question in the back?
What qualifies as a disorder? I mean, what makes it?
Yeah, so there's I won't go down the rabbit hole. There's actually a lot of argument about what is the right threshold for a disorder, particularly for a mild disorder. So I'll leave that aside. Effectively, what is DSM disorders? So you have to meet 2 or more of 11 criteria for a substance use disorder. So that's things like wanting to stop and not being able to, intense craving that's hard to manage, using to a degree that's causing consequences. And we'll talk a little bit more about what that looks like. Please.
Do you think that this includes the high functioning addicts? I feel like that it would be really hard to diagnose if they're moving up on like it's still
This is a great question. For folks online who couldn't hear the question was, does this include people who are high functioning and have a substance use disorder? Absolutely. So this is where the threshold gets sort of really tricky and where again you see context matters. So if we take, for example, a 21-year-old college senior and a 43-year-old with 2 young kids and a full-time job, that the degree of alcohol use, even the impact on alcohol use, even to some of these symptoms could have tremendously different functional impacts. If you're a college student, your first class isn't until 11 and you feel crummy in the morning because you're kind of hungover, the impact of that on your functioning is much lower. The social norms are much different. So there is that piece of the context actually matters. And there are people, and this is a huge debate in the field, historically treatment was about abstinence. That was the goal, is you had to get to 0. That is not the standard for anything else that we have in any area of health. You know, I always use depression as an example. If our threshold to get better from depression is to have 0 depressive symptoms at all, we would have no treatments that work. That's to some extent what we expect of addictive disorders. And there are people who can reduce substance use, have symptom reduction, have functional improvements, and do fine. You know, obviously they might do better if they get down to abstinence. I'll talk a little bit about that sort of reduction versus abstinence a little bit later, but absolutely this includes that. And I think that is where there can be some controversy is of that mild substance use disorder bucket, how many need treatment? How many will actually age out of that, will adjust on their own? How many of those people actually progress to more severe disorders? And it's a really important research question. So if we have particularly someone who's a little bit younger, how can we predict, you know, who's going to do okay with maybe a little nudge and a little support, and who's actually at risk for escalating to a pretty severe disorder? Great question. All right, so I do want to mention, because this befuddles me, and maybe somebody has a great thought about this. There's some interesting things happening with youth, where substance use is actually plummeting in youth, with the exception of vaping, and to some extent, smokeless tobacco. So there are some things that aren't going well in adolescence, but these are, so what you're seeing here on the left, these are data from the Monitoring the Future study, which is a study of 8th, 10th, and 12th graders. It's a national study. It's been going on since the mid-70s. And what you're looking at here is proportion or prevalence of any alcohol use in the past year. So you can see sort of mid-70s up into the early 90s, you're looking at about 80% or more of college seniors drank at some point. This has been decreasing over time. There's some funky stuff that happened around early days of COVID, to the point that we are at by far the lowest levels of drinking in high school students, and as long as we've been surveilling this. These are tremendous drops, and it's actually now under 50%. So what's going on here? People have a lot of theories. I don't know that anybody actually knows the answer to this, but just some interesting backdrop. Yeah, please.
So no, Adam and I have been talking about this a lot, organizing HBI events, just even for adults, like the amount of alcohol like that we order has been like incredibly reduced.
It's so, and you can see the cultural changes. If you go to a restaurant now and you flip to the section that used to have cocktails, what do you see? In addition, you see mocktails. Right. Now, gotta love the restaurant industry. You can charge $15 for a drink and not have to put gin in it. So there's a business model for you. We're all in the wrong profession, but you can really see this shift. I would say every year for the past 4 years, I get a request, and I would say no, to do some kind of media around dry January. Everybody wants to talk, dry January has to be on the news every year. And that to be the most boring topic to talk about on the planet, but please.
I think it's interesting that the dip really starts around like 2007 when the first iPhone came out. I don't know if you're familiar with like John Haidt's work, but like the social disengagement of youth really started happening around then. So I actually think another layer is that the social engagement atmosphere is largely reduced compared to what it used to be.
Yeah, for folks online, the point was that some of the dip happened around 2007 when the first iPhone came out. So there is, I would say that is probably the hypothesis that I've heard the most, is that the degree of social engagement has changed so much. And you know, there's a lot of data actually in adults too, that the proportion of time that people spend in their own home has gone up tremendously. It's actually stayed high, even again through our evolution post the belly of the beast of COVID. So, you know, it's this is one of those things where it's, I would argue, good news for all of these brains that they're not being exposed to alcohol at 16, and probably a harbinger of nothing good for this whole cohort if this means people aren't actually engaging socially. So one other point I wanted to make on the sort of substance use to substance use disorder, just because I think these numbers are helpful. Now I take these numbers with a teeny bit of a grain of salt because this is a little bit hard to model, but in general, proportion of people who are exposed to a drug who will develop a substance use disorder, I'll just sort of zip through these. Pardon the tremendous span here on nicotine. The data are really all over the place on that, but this is just to get a sense of, I think the perceptions of these numbers tend to be very different. That we think of something like alcohol as very, very safe and something like cocaine as very harmful. And obviously the degree of harms differs quite a bit, but in terms of sort of likelihood of addiction, these can actually, the vast majority of people who use these things won't develop a substance use disorder. This is another place where, in terms of the public health messaging, people love things that are black and white. People love a binary. Tell me this is good or this is bad. There was an interesting semi-controversial book that came out a few years ago that I'm now blanking on the topic of, but basically it was like, everybody should use drugs, like drugs, but basically arguing some of this former cocaine use disorder researcher who said, look, they're not that risky, go for it. Use cocaine, use heroin, as long as you don't have a psychiatric disorder, you're not at risk. I think that's probably not a great public health message. The reverse, that if anyone comes anywhere close to these, they're going to be living under a bridge, is also not particularly accurate. So let's talk a little bit about the continuum of substance use. So as you're thinking about substance use, particularly substance use in the brain, substance use in treatment, how do we think about addressing these disorders? I think it's always helpful to orient to what is the continuum here. And you can think about really 4 major touch points. Yes, please.
Actually, going back to that,
Yeah.
what's the, for heroin or those kinds of drugs, what's the number?
Yeah, I didn't include an opioid number because the opioid numbers are a little all over the place. We don't actually have great estimates for that. The best data that we have, I would say, would put it lower than nicotine, higher than cocaine. But you're also talking about really significant differences in terms of, are you talking about heroin versus an oxycodone or an opioid analgesic? But yeah, not great numbers. Yes.
Are you using dependence interchangeably as you do here?
Sorry, apologies. Yeah. So this is actually an old, in Parks these data are a little bit older. The old DSM diagnoses were substance abuse and substance dependence. So this is not physiological dependence, it's the old DSM disorder. You can think of it as sort of an equivalent to a moderate to severe substance use disorder in DSM-5. Thank you for clarifying that, yeah. Okay, so you can think of sort of 4 key touch points here. Is sort of what's going to cause someone to try a substance. You can't have a substance use disorder if you're never exposed to the drug. So you have sort of your entry point. What's going to tip someone into trying a substance? What's going to tip someone from trying a substance to repeating it, to continuing to use? From continuing to use to developing problems, and from developing problems to continued use despite problems, which is where we get into addiction territory. And at any of these points, there's some risk, obviously greater risk as you move farther along. And we heard a couple of these themes earlier on. If you think about why does someone try a substance, a lot of this is social and cultural. We heard before, what's available? What is in your environment? What can you get your hands on? This is where people probably heard the term gateway drug. You've heard this before. This is an impossible thing to try to study within our ethics guidelines. But in fact, people say, well, a lot of people will use cannabis before they start using other drugs, therefore it's the gateway. And cannabis should be regulated like heroin is regulated because this is the thing that's going to open up the floodgates. Now, do you think it's easier to get your hands on cannabis than it is to get your hands on heroin or methamphetamine? Yes. You ask to poll any 17-year-old and say, what could you get me in the next 24 hours? And probably most aren't going to know how to get heroin or methamphetamine. I would suspect at this point every one of them would know how to get cannabis. So if you think about the availability, this is going to be one of the big things that's going to influence what's used. If you look globally, the predominant substance use problem varies based on, again, what's available in the culture. So there's a lot of cocaine use disorder in South America, where there's a lot of cocaine production. In the Middle East, you see a lot of opioids. In Australia, you see a lot of cannabis and alcohol. So you'll really see these variations. You can also see them within the US. The other couple factors here are, is it acceptable? Does my family, my subculture, my soccer team, the people at work, is this an acceptable thing? And then the third is expectancy. What do I think is going to happen if I'm going to use? I think it's gonna be a good thing, do I think it's gonna be a bad thing? So this is really, and certainly there are individual differences, things like impulsivity, things like sensation seeking, people who really want to experience something different. Certainly psychiatric and trauma history can influence these things, but you can see really there's a lot of external factors that influence the door in. This slide I love. I wish I ever saw a correlation like this in any of my own research, but so these are also monitoring the future data. I mentioned this before, mid-70s up through 2019. What you're looking at in this blue line, this is a percentage of 12th graders who said, I think it would be harmful if someone used cannabis occasionally. It's probably not a good idea. Your green line here is the percentage who used. So you can see over time, you see actually huge swings in perception of cannabis, whether this is harmful or not. This is a fun historical game to play if you want to look at actually the years where things tipped. But you see that really parallel. As perceived risk goes down, use goes up, vice versa. This is not just the case for cannabis. This was also a really interesting component of the early stages of the most recent opioid epidemic, where prescription opioids or diverted prescription opioids were a huge piece of the puzzle, and perception, particularly among youth, of the risk of those was rock bottom, which sort of makes sense. If I think, okay, this thing's in grandma's cabinet, this can't be that risky, likelihood of saying, sure, I'll try this is going to be very different. Yeah, please.
It's kind of a tricky question, but I always wondered that acceptability, whether that some way influenced the predisposition to getting addicted versus exposure, that maybe, if I'm explaining myself correctly, like those percentages that you showed, only 15% of who have explored cocaine will actually become compulsive or SUD by DSM. Whether the acceptability in the culture or wherever it is, location, geographically, whether that shifts based on that. Because a lot is about the cognitive tendency, which you being a psychologist, we rarely talk to a psychologist in this environment, you bring that wealth, that this whole personality thing that psychology defines, but basic scientists are not considering, are cognitive tendencies. We don't know how they're ingrained in the neural circuits. But if you can actually model them, then, if I'm okay that I will try it, I'll probably have, even being a risk-taking individual, I'll probably have less, compulsivity towards transitioning. Did I explain myself right?
You did, and I so appreciate this, and this is where I think back translational research is so important. As a psychologist, so much of what I think about, and so much of the way that we frame things is in terms of individual differences and things like personality. So even again, if we think of that continuum, that I promise I won't take us off on too much of a tangent here. We think about the DARE program. People familiar with DARE? Anybody actually have to sit through any DARE sessions back in the day? All right, we got a few people. All right. So you think about
The
DARE.
essay contest in my DARE class.
All right, there we go. All right, we have the DARE essay winner here. We need to hear about that later. But here's the thing. So DARE and a lot of these, and I remember when I was in high school, the strategy for educating kids about substance use was scare the bejesus out of them. That was the goal. I remember, I don't know if anyone had this, it was you dropped the car off a crane to show what would happen if you got into a drunk driving accident. That was, okay, someone else saw that, yeah. So what happened? So you think about that. Okay, now we have this prevention intervention and we have all these youth here. You are in that group of youth going to have some people who are going to look at that, and I was one of these kids, you put someone who's a little more on the neurotic end, maybe a little more on the anxious end. I see that car and I think, oh my goodness, I bet this is devil juice. I better stay very far away from this. This is awful. Look at that car. What happens to the more impulsive, maybe a little bit less punishment sensitive 15, 16-year-olds? What do they think? Let me try it. That looks cool. Did you see them? They just dropped a car off a crane. So you can see this, and that's one of the things where a lot of the data on DARE and those programs has really fallen through, because the people that those models would convince are probably not going to be the people who are going to be experimenting with a lot of substances to begin with, and the people who it's not going to convince are now intrigued. So that influence of personality is huge in terms of whether or not someone's going to get over some of these thresholds. And I'm not going to speak about it articulately, but I'm gonna nod a little bit to some attempts that we've done at sort of trying to back translate some of that. Yeah, question back.
Do you have any speculation as to what could be happening at about 2010, where it looks like correlation has just fell off completely?
Yeah, so I'd say in terms of the actual number, that's still a pretty moderate correlation. If you actually look at these are sort of freakishly strongly correlated up until about then. I would guess it could be access. I think once you see, because now you're talking about more and more states legalizing, the shift in access, I think, can really make a difference in terms of actual use. How easy is it to get your hands on it? But that would just be a guess. All right. So why do people keep using substances? I'm going to sort of walk through this one relatively quickly. This is good old-fashioned positive and negative reinforcement. This is a simple story, but I'm going to add where the story gets more complex. So again, you've got your positive reinforcement. If someone uses alcohol, again, for the first time, for the second time, if it feels good, if they enjoy it, they're likely to repeat the behavior. If they get some relief, maybe they were feeling pretty down, pretty awful, and it gives them relief, they're likely to repeat it. Okay, this is super, super basic. Why am I bringing this up? Is there also going to be differences, and here's where we start to see some differences in the brain, and also in metabolism of substances. This experience is going to be different across individuals. So for example, one of the big sort of genetic risk factors and family history risk factors for alcohol is when we all drink alcohol, when anyone drinks alcohol, there are a lot of positive effects on the front end. There's some stimulant effect, you get some energy, there's some of that sedating effect, you feel a little bit more relaxed. On the back end of the alcohol curve, as that alcohol is starting to come out of your system, there are a lot of negative effects. Like what? Anybody think of one? The back end. Hangover. So certainly hangover is sort of your worst case. Fatigue, you can have some nausea. There's sort of that curve on the back end. How much time and how aversive that back end is makes a huge difference. One of the big risks for someone, again, you see this with a strong family history of alcoholism, someone who's metabolizing alcohol quite well, they're actually not going to get as much of that negative effect. So you imagine your first exposure to the drug is lots of good and very little bad. That's the kind of situation where you could really see someone escalate. If we look at sort of the other part of this, if you have someone who has a psychiatric disorder history, childhood trauma history, where that stress system is really on overdrive, and it feels like, gosh, this is actually something that takes the temperature down, you're also going to see vulnerability for this. So this is where, as we think about prevention, I think this is a big piece of the puzzle. When we then get to negative consequences, and I'm not going to talk a lot about this, but certainly there can be, the very simple way I think I tend to think about this is you have your health consequences that we might think of for any health behavior. So things like regular substance use is a risk for, you name it, cardiovascular disease, dementia, psychiatric illness, cancer in many cases. What are some other things that also would be risk factors for all of those things? Any other health behaviors? Cardiovascular disease, dementia, psychiatric illness.
Risk taking.
So risk taking can certainly be one. Diet, sleep, exercise. So in some ways there is sort of a health behaviors element to this. If someone is, and this is I think where a lot of the public health messaging is now, is hey, even relatively low levels of alcohol can have a small incremental increase in health down the road. I think we're in health behavior territory there. Once we start to get to heavier or more regular substance use, the consequences become more acute and they become more significant, including functional consequences, which came up before, is how much is this actually influencing your life? Now, sometimes you will see someone who will, again, we'll use alcohol as an example, they're using alcohol or they're using cannabis, they're using pretty regularly, they're escalating, and they have a negative consequence or two. They have a fight with a family member, they find that they're coming to work late, maybe they get in trouble at work, and they shift the behavior. Gosh, I need to, or someone has a kid, has their first kid, and they say, gosh, I just can't do this anymore, and they stop or they cut back. Where we sort of see the distinction with addiction with a substance use disorder is those negative consequences start to happen and people feel like they can't shift. This is where you really get into this idea of control. Is loss of control over the substance use. Is I want to stop, but I can't. Talk a little bit about what that looks like. What happens also is with chronic exposure to a drug, there are also changes in the brain that actually throw fuel on this fire. Things like difficulty with executive function, inhibitory control makes it even harder to inhibit that. You start to see a shift where natural rewards are no longer rewarding. So the example I always think of with this that was a little bit heartbreaking, someone I worked with who had an opioid use disorder, who had young kids, and he used to love going to see his young kids play soccer. Loved it. It was like the highlight of his week. Every Saturday they played soccer. He developed a prescription opioid problem. And one of the things he said when he first came in is he said, I go to my kid's soccer game and I feel nothing. Absolutely. I don't even feel bad. I feel nothing. And he felt horrible about this. This is the thing that matters to me more than anything else. And all I can think about is the drug. So you start to see these changes in the brain that actually, again, amplify the ability or the inability to stop. Please.
Sorry, I was wondering, I'd love to like hear your perspective if you could overlay this idea of willpower and volition on top of this, because it seems like they're very different, but their substance use disorders is a really unique landscape for both of those to start intermixing in a way that I think is kind of hard to measure. So be curious if you could talk about how that crops up.
I love this. Hold that thought for
Okay.
1 second. My next slide, I'm actually going to hit this on this sort of topic of sort of quote unquote willpower. And what does this actually mean? We're speaking the same language here, which is this ability to shift between now and later. So this is where I want to sort of think about lack of control. And I want us to all do an exercise together here. I won't actually make anybody say anything, don't you worry. I'm a big ol' introvert. As soon as someone says exercise, I'm like, where's the exit? So you can do this internally. So I want you to think about sort of this idea of willpower, this idea of control, because this is the thing. This is the thing that people will say when they come into my office, or family members will say when they come into my office, they'll say, why can't I just stop? Why can't my sibling, my parent just stop? This makes no sense. It's ruining their life. They've lost their job. It's impacting their health. This makes no sense. Aren't we rational beings? Here's what I want you to think about in terms of this idea of willpower, is we think a lot about pros and cons. You know, when the pros and cons list gets to a certain balance, I should stop doing this thing that I'm doing. But I want you to think about not just pros and cons, but now versus later. So I want everyone to take a moment, and I want you to think about a reward behavior that you engage in that's maybe not the healthiest. Food is always a good example. I'm going to talk about food for myself. The thing that you do that you probably shouldn't do, again, food is a good one here. Certainly if anyone wants to use substances as an example, or phone use, whatever that might be. This is mine. I love ice cream so much. As a kindness to me, when they were putting together my lab website, all the team members put their favorite ice cream flavor in their bio. So this is the level we're talking about. This is the JP Licks in Harvard Square, for anyone who's familiar with it. This is my cone. So I want you to think about, you have your guilty pleasure. Everybody have one? Okay. So again, this pales in comparison to talk about the level of reward with the drug, but just for the sake of demonstration. So let's say I am trying not to eat ice cream anymore. My primary care said, look, you have to consume less sugar. This isn't good for you. My family has said, like, enough with the ice cream, Kate. Like, this is impacting you negatively. You have to stop. So I'm walking down Mass Ave in Harvard Square. It's a beautiful day, and the door to JP Licks is open. And I can smell the cones. People know what I'm talking about with the cones. I can smell the cones. I can hear people laughing. I can see the kid with chocolate ice cream all over his face, looking happier than anyone's ever looked. If I keep walking, if I at that moment make the decision to not engage in my guilty pleasure, again, you can all keep your own version in your mind here. If I make that decision in that moment, what benefit do I get right now?
Ice cream's pretty good.
Ice cream is pretty good. It's pretty damn good. Yes. If I keep walking, I get nothing. Can I maybe give myself a pat on the back that I decided to walk by JP Licks? That's not super compelling to me, or to most people. I get nothing. If I abstain from ice cream on that one day, that one ice cream cone fewer in my life, does that have any measurable impact on my cardiovascular health? Nope. Not a bit. What happens if I take that right and I go into JP Licks and I get an ice cream? From the back, I heard ice cream is pretty good. Pretty good. I'm gonna feel good. I'm probably gonna get a mood boost. It's gonna taste good. I'm gonna feel better. Their cones are extra crunchy. You gotta love that. You get crunch. So when you're thinking about this, when you think about this idea of willpower, so often we think about it's a pro and con. Why would you engage in this? You should just resist. But when we think about resisting a reward behavior versus engaging in it, everything has to do with how proximal or distal the reinforcement is. For the behaviors that are hardest to change, the reinforcement is quick and proximal, and the benefits tend to be diffuse and long-term. This is why it's hard to get people to eat healthy. This is why it's hard to get people to exercise, because on any given day, if we choose a chicken Caesar salad tonight or a bacon double cheeseburger tonight, that has no measurable impact on our health in the long run. So this is where I think that willpower issue gets really tricky. Now again, multiply this by a lot if you're talking about something with a level of reward and reinforcement of a drug. Yes, please.
Is there any even singular example where that's reverse of it? Because that feels like for anything, right? Any substance of use, is there any example where you will immediately perceive like it being beneficial? Is there any example otherwise?
You mean sort of like a non-reward behavior?
Yeah.
This is where it gets tricky. This is where, as a psychologist, I tend to be transparent with people, which is I'm gonna have 1,000 skills, 1,000 things I can throw at you. None of them are gonna be as powerful in the moment, in all likelihood, as a drug. And that is part of what we're really contending with. One of the things that I always think about in treatment is how do we bring a proximal reward for a healthy behavior? And that's you. So exercise is probably the simplest example I can use here. If you think about trying to motivate someone to engage in exercise, which can also be good for substance recovery, if you try to motivate people for long-term health, weight and shape, really hard to get people to do that, because those are all distal, they take time. What's a proximal benefit you can get from exercise? Endorphins, mood. So getting people, so for example, if I'm trying to get someone to engage that kind of behavior change, I want us to track mood. I want us to think about what is the benefit you will get in that episode for mood. Social connection is the other one, if you can get someone to exercise with someone else. So a lot of it is how do we think about pushing up the reward. I'm not gonna get into this in part for the sake of time, but to some extent the most powerful behavioral intervention we have is contingency management. People familiar with this term? So effectively, what contingency management does is it pulls up the reward and makes it more proximal. So the way that this tends to be implemented in substance use disorder settings is someone comes in, let's say they have cocaine use disorder, and they come in and they do a drug test of some sort, typically a urine drug test, and it's stimulant negative. They would actually get a reward or get a chance at a reward. So it's actually over at BMC, they have actually one of the few programs around here that does this, where they have a clinic in the community where folks come in and they can get rewards up to some certain level, either a good or a voucher or something like that. And what you're doing is you're just pulling the reward more proximally. We're terrible, particularly when stressed, particularly if you're dealing with an addictive disorder, at that delay of gratification. There's a question in the back, please.
I mean, people I know who have these smartphone apps that track their health, they get kind of obsessed by their score. I mean, is there a way to score these things so that physiologically they track, I don't know, weird fluctuations if you take a drug, and then give you a negative, low score for that?
Yeah, so there have been some attempts at sort of basically different, whether it be either gamification or some kind of reward related to that. In general, there's been some evidence for that, but I think there's a lot of work to do in terms of that, because that's, to some extent, you're actually leveraging some of the same process, which is this oversensitivity, this hypersensitivity to short-term reward. Is how do I engage in that? The tricky part, and you see this both as a vulnerability for addiction and something that tends to get worse in people with an addictive disorder, is you get punishment insensitivity. So loss tends to not be felt. And I think sometimes like the sort of public perception, sort of stigmatized view of that is like, you don't learn from your mistakes, you don't care if you're hurting other people. It is an actual neurocognitive deficit that we can demonstrate in the lab, which is an actual inability to learn from and to respond to punishment. So in general, the sort of taking something away doesn't tend to work. It's more of the reward-based model. So again, when we think about choice, and I'm glad someone raised choice early on, when we're looking at this idea of choice, there are so many thumbs on the scale of choice once someone is struggling with an addictive disorder. And I'm not going to go through all these, but things like the drug reward is greater than natural rewards, drug craving, the immediate needs beating out long-term needs. This is part of what we're contending with, which again, on the surface, it seems like this should be easy math. You have a behavior that's having catastrophic consequences, but you're really seeing, again, sort of the thumb on the scale of this. And I realize we've had a great discussion here. I've fully lost track of any time on slides, so I'm actually gonna skip to sort of one other thought, because this is again where I want to talk a little bit about sort of this idea of translation, back translation for just a minute, and then I want to make sure we have time for some additional questions. So back to my continuum here, sort of who is at risk. And again, here is, as folks are thinking about this, certainly anyone who's interested in doing any study in this area, is really thinking about how do we understand each of these touch points, because the impact is going to be different. Has drug already hit the brain or not? Or are we looking at sort of vulnerability prior to the drug? So I'm going to use the example of sex differences here. I'm just going to walk you briefly through this. So in general, substance use disorders are more prevalent in men or women. It's men, actually. So if you look at, this is a birth cohort study. So you look at people who were born sort of late 19th century, early 20th century, men were about twice as likely to drink, about 3 times as likely to have an alcohol problem than women. You zoom forward 100 years, this has dropped tremendously. Now, how does this make sense? How does this make sense from the perspective of biology, from culture? So there are a few things to think about here, and I'll just add, it's not just alcohol, this is also things like opioids, that you tend to see sort of drops in that sex gap. So why is this shrinking? So there are a few hypotheses here. One was maybe there are differences in access to drugs. And in particular, and this is one that always bums me out a little bit, is that countries with greater equity in participation in government, workforce participation, education, tend to have smaller sex differences in the prevalence of substance use disorders. Those with less equity tend to have more of a male to female ratio. So we looked at this in a couple of studies recently. So cocaine is one, a bunch of cocaine. So these are cocaine use disorder estimates, men versus women. It's about 2.5 times more common in men than women. So stimulants is a place where you actually tend to see, in many ways, the biggest sex difference. So what we looked at is sort of where along that continuum do you see those sex differences emerge? And this doesn't give us a perfect picture of how much of this is culture, environment versus biology, but gives us a little bit of an indication. I apologize, this one is super ugly, but I'll walk you through what we're looking at here. So we started with how difficult or easy would it be for you to get your hands on cocaine? So this is to some extent like our access question. Can you get in the door? And you tend to see a sex difference here. So here you're looking at it's nearly impossible, very difficult, fairly easy, very easy. To confuse everybody here, it's like a stroop. The pink is men and the blue is women. So you see women are more likely to say it's nearly impossible than men. So we'll talk about this a little bit. So it's a little bit harder to get in the door. Then once we take only people who said they thought they could access it, how many people would try it? So here you see, sorry, my colors change here, women and men. Men are more likely to try cocaine if they have access to it. And again, the scale here looks relatively small, but again, men are then more likely, if they've tried it, to develop a substance use disorder, develop a cocaine use disorder. Here are just sort of odds ratios, if people like to think of this in terms of numbers instead. So men had 1.16 times higher odds of access, 1.79 times higher odds of use, and 1.39 times higher odds of a use disorder. In other words, we actually see that difference accumulate at each touch point. Now, mechanism is a question here. This is the one that I'd be curious if folks have any thoughts about. I would postulate that we're looking at maybe more social and cultural influences on this end of the continuum, and we probably get into more biological and brain-based differences as we move farther along. Is that true? Beats the heck out of me. We don't have data on this, but I think what this really does is this, for me, demonstrates that we're really looking at an intersection of both of these things. And the last thing I will mention, because I do want to know, I don't know if anyone knew Elena Chartoff, who's a colleague who tragically passed more than a year ago now, just like a absolutely as wonderful a scientist she was an even better person. And to the point that you had made before, we were starting to do some work on sort of back translation from some of what we're seeing in terms of sex differences in humans into an animal model. So I won't necessarily walk you through this, but some of the differences that we tend to see, women more likely to use substances to cope, having a greater impact of psychiatric illness on the escalation to substance use disorders. We've demonstrated this in a number of different disorders, including opioid use disorder, basically any measure we see. You tend to see people who are more intolerant of their distress are more likely to use substances, which you might expect. It's that sense of I have to get rid of it. And unfortunately, this work was something that was really cut off. But, and please don't ask me to explain her rodent model here, but Elena had managed to back translate this by having basically a model of higher distress intolerance rats, lower distress intolerance rats, and looking at whether or not that would predict oxycodone self-administration, so escalation to sort of a rodent model of an opioid use disorder. And what you actually saw was distress intolerance mattered in a sex-dependent manner. So we actually have a behavioral model that she had started to build that would sort of let us build on to try to understand some mechanism. Again, unfortunately, that's not something that we followed up on yet. But I think this is part of the real promise in terms of not just translation, but also back translation. How can we start to look at some of these intersecting factors? And why don't I stop there? I was going to talk a little bit about treatment, but I'm happy to answer questions about treatment. But why don't I pause here for any questions folks have? I'm nervous about ending on the rodent slide that y'all are going to ask me questions about that. Yes, please.
So in the human context, is there any data on which gender rehabs better? Like if you put men and women in rehab, who relapses more? Is there?
Yeah. Great question. So in general, doesn't tend to be a difference. You actually see very similar, if you look, this is where you gotta love that people can say whatever they want with the data at some point. If you look hard enough, you might find one or two studies that find a greater risk of relapse in women. In general, if you look at the literature in its totality, men and women tend to do very similarly.
The only reason I ask is there seems to be that tendency in rodents. You see a skewing. I do, so technically. And I didn't know, sadly, that Elena passed.
Yeah. Yeah, she was just incredible, really an incredible person. Yeah, and it's been one of the, something that she and I talked about a lot is you do tend to see it, particularly in terms of the, sex differences in addiction, that the rodent and human models tend to point actually in different directions at times. And what's actually going on there? Is that we're not able to model some of the social and cultural factors? Is it something different? Is it, but I think that's an area for a lot of future study. Yes, please.
Sorry, what's past translation?
Back translation. So in part what is taking something that we see clinically in humans or behaviorally in humans and then trying to come up with, for example, a rodent model of that same. The question came up before about how do we sort of account for things like personality. So we have another study that's going on, and unfortunately we don't have data quite yet, but where we're looking at this concept of harm avoidance, where again you see huge variability in humans on the degree to which people sort of seek out risk taking, you had mentioned before, versus tend to be harm avoidant. And we have someone who's actually over at BU who's working with a rodent model where she sort of has sort of two different models of a more harm avoidant rodent and less harm avoidant rodent. And then what we can do is see if we expose them to things like opioids or cocaine, do we see actual prediction of risk? So that's sort of one sort of proof of concept. Do we actually see the same risk factors in that model? Once we know we have the model, we can then start to look at mechanism. Yeah, please.
I did get a chance to talk about the feedback, but I think that one of the challenges with these different substances is the nuance between them. And like, I know for like nicotine, there's some available like medications that you can take to make it noxious, and that's sort of like a punishment rather than a like proximal reward. But then for a lot of other substances, we rely on like social interventions, like 12-step programs that by far seem to be the most successful. I wonder like what your thoughts are on trying to parse out as we think about like, different substances, how unique we need to treat each one. I mean, it's kind of like a
Great question. I feel like you just teed me up for like the slides that I didn't get to present, so I appreciate that. This is not a plant, I promise. So I think there are two things to keep in mind. So when it comes to our behavioral interventions, those tend to not be drug specific. So things like whether that be, so here, you know, sort of more cognitive behavioral or mindfulness based, sort of more structured behavioral treatments versus more mutual support kinds of treatments like 12-step programs. Those tend to not necessarily be as drug specific. It doesn't. The same principles apply because you're talking about behavioral principles, which are going to apply across the board. When you get into medications, it starts to get much more drug specific. One of the challenges is this slide actually. So if you look at the bottom left here, this is among people with a substance use disorder, only about 25% only use one drug. So once someone has a substance use disorder, in all likelihood, you're talking about multi-drugs on board. This we actually don't know as much about, in part because there's such a push in research to do one thing at a time. I can't tell you how many times I fight with grant reviewers when they say, okay, you're gonna do an opioid use disorder study. I want you to exclude use of any other drugs. And I said, well, if you can find the 3 people in the country who have an opioid use disorder who don't touch any other drugs, please send them my way. And we'll see how well we do with that. So this is part of the issue, but in terms of actual medication development, that does tend to be largely drug specific. So for example, our most effective treatment on the medication end is for opioid use disorder, where we have both agonist or partial agonist and an antagonist at the mu opioid receptor. So you're really hitting where's the opioid actually going to influence reward, where's the opioid actually hitting the brain. So in general, the more precise the treatment is targeted to the mechanism on the medication end, the better it tends to be. Where you see things, just like actually really in any place in mental illness, where it's a, you know, we're sort of hoping for the best, we're hitting like one of probably 20 mechanisms and we're going to see what happens, you tend to see the effect sizes drop. But yeah, polysubstance use is a huge piece of this. If we have a junior faculty member in our department who's really interested in this topic of addiction switching, which is sort of the idea that, and we see this all the time, someone comes in with an opioid use disorder, they get treatment, they're doing great, and then 3 months later, I walk up to our detox unit and they're being detoxed from alcohol. Or even at the lower end of severity, someone has sort of problem levels of drinking, they're looking to reduce, I was actually talking to someone about this just yesterday, reduce drinking and junk food consumption goes up, or time playing video games goes up. So there is also this issue of maybe we're doing a great job with the opioid, the alcohol, the tobacco, but there is sort of this overcharged reward seeking that's going to bubble up someplace else. That we don't have great treatments for at this point. In part because I don't think we understand that process all that well yet. Yeah.
Is there a way to behaviorally benchmark? You know, psychiatry is riddled by the problem of not having tests. If you got diabetes, you walk in to get your blood drawn and get the number. This gets even worse compared to, you know, schizophrenia or whatever. So if you bring in a patient, is there a way through a questionnaire of giving them puzzles, or in which situation they would respond like what? We can have a behavioral benchmark that this person is in this stage and might actually advance further.
I think in some ways that's the holy grail, is can we actually identify those? Because I think identifying those also means that we have a better sense of mechanism at some level, whether that be cognitive mechanism, behavioral mechanism. Do we know what we're actually targeting? It also raises the issue of heterogeneity. So here's it, speaking of medications, the interesting, people probably see this in the news, GLP-1s, everybody saying, well, wait, people are they're quitting smoking, they're reducing their drinking. Not everybody. Some people are, and there's been a lot of preclinical work on GLP-1s for stimulant use disorder that have had some mixed success. there's so much heterogeneity within the phenotype that we see of a substance use disorder that my guess is there probably is potential for that. But is this really one class of disorder? Is this three? You know, if someone develops an alcohol use disorder in their mid-40s and they've had PTSD and maybe they've had a second traumatic event, now their PTSD is worse, is that the exact same disorder as the person who started drinking at age 9 and sort of shot out of a rocket in terms of level of alcohol use? My guess is we're actually probably looking at pretty distinct disorders. But to sort of circle back to your actual question, I think that is the real holy grails. Can we figure out what are the right tests, both to understand the disorder better, and quite frankly, we have a real issue with getting treatments through the regulatory pipeline if you don't have a great way of measuring outcome. And basically our way of measuring outcome right now is abstinence. And we're basically setting the bar very high for this one class of disorders. We're saying you need to get to perfection for us to approve a treatment. Yeah.
First off, just thank you so much for your talk. Really appreciated your energy throughout, and just the way you kept asking questions to the audience just felt very engaging throughout. So thank you so much for that. My question is about the sex-based differences, and it's more so about how the sex-based differences are measured, and it seems to usually be measured just female-male. Is there any research out looking at it on any other type of scale?
Yes, so great question. That research was growing. And yeah, probably don't need to necessarily finish that sentence. In general, what you tend to see in that research is the groups that tend to be either more stigmatized or minoritized tend to have sort of worse indicators in terms of risk for substance use. You're almost certainly looking at sort of minority stress-based models there, but it's such a small literature that's just, again, was just growing and is almost certainly going to be derailed, at least let's hope for just the short term. But yeah, I mean, that's, again, we talk about social and cultural factors. Here's a whole other can of worms if you start to look at minority-based stress, discrimination. You know, in the grand scheme of things, discrimination-based stress is about as bad as it gets in terms of negative impacts, along with traumatic stress. Yes.
This might be a little naive, but do you think it would ever come to the point where, just say alcohol, substance disorder, that they would find some drug that would get that part of the brain to change things rather than always trying to change your behavior or try not to drink? I mean, is that something you think would ever happen?
Yeah, I mean, I think there's two possibilities for something like that. So I think one possibility, and there's been a ton of interest in this, is actually vaccines for substance use disorder. So there was a lot of work years ago on stimulant cocaine vaccines, and there's been a ton of work in the last 5 or 6 years on fentanyl vaccines. It's basically, can you vaccinate someone against the effects? So if they took the drug, they probably wouldn't overdose and it wouldn't impact them much. Complicated as it gets, in part because the receptors that these drugs act on, we also have for a reason, and you have all kinds of issues and things, including if you're messing around with opioid receptors, what happens when someone has a acute or chronic pain illness, and we need to get some pain relief on board. So that, I think, has been one area of interest. I think in terms of, can we get to sort of like a broader medication, I think there's a step that would have to happen first, which is to really honestly better characterize the disorder itself. And this comes back to the issue of sort of measurement and biomarker. Is right now, I mean, we could talk about 50 different folks with substance use disorders. Their symptom profiles could look entirely different across all 50 of them. There's so much heterogeneity there that I don't know that we have a target now. I think it's probably going to really depend on understanding the heterogeneity and the disorder better. And again, this one disorder is 10 disorders. All right. Thank you so much, everybody. Appreciate it.
Anyone who'd like to, who signed up or would like to join for the lunch,